Hello, everybody. Welcome. Bienvenue, Pjashig, to the March edition of the Public Health Virtual Journal Club. I'm Danielle Tremblay, and I'm the Communications Manager at CPHA, and I'm going to be your host today. So I'd like to acknowledge that while we're all coming to this webinar from different parts of Turtle Island, CPHA's office and my home are located on the unceded territory of the Algonquin and Anishinaabe Nation. CPHA is committed to meaningful truth and reconciliation with all First Nations, Inuit, and Métis people, and to that end has established an Indigenous Advisory Council to guide its path towards reconciliation. A few housekeeping notes before we begin. If you'd like to ask a question, please do so by using the Q&A module. We are recording the webinar and it'll be available on our YouTube channel. And now, without further ado, it is my pleasure to introduce Monica Imode, the student member of CPHA's Board of Directors, who will moderate today's session. Over to you, Monica.
Thank you, Danielle, and thank you everyone for being here today. It's my pleasure to welcome you to our Journal Club series that's held in partnership with the Canadian Journal of Public Health. So at CPHA, one key area of our work is to advocate for public health, speaking up for people and populations to all levels of government. We champion health equity, social justice, evidence-informed decision-making. We're a catalyst for change that improves health and well-being for all. And our vision is a healthy, just world, and our mission is to enhance the health of people in Canada and to contribute to a healthier and more equitable world. And you can find us on Twitter at CPHA_ACSP. The Canadian Journal of Public Health is an independent journal that publishes peer-reviewed original research and scholarly articles submitted in either English or French that are relevant to population and public health. This journal aims to advance public health research and practice in Canada and around the world, contributing to the improvement of health in populations and the reduction of health inequalities. So for the past 4 years, we've been holding a webinar series to engage our members. Initially, the series was primarily intended for students, trainees, and early career professionals with the goal of promoting public health careers. You can find the recordings from these past sessions on our YouTube channel. So this year, we're holding a series in partnership with our peer-to-peer journal that we publish, the Canadian Journal of Public Health. Each month, a graduate student will critically appraise a different journal article and will engage the paper's authors in discussion. So a committee of devoted volunteers have identified all the papers for these sessions, and registration for these webinars open up a month before them taking place. And so our hope is that this Journal Club series will provide a supportive learning environment for participants to keep abreast of the current public health literature, help you develop some skills and competencies in critical appraisal, and will expose participants to a range of methodology and analytical approaches used in public health research. We hope that you find these sessions to be as enjoyable as we do, and we hope that you also will follow along with the conversation on our Twitter using the hashtag CJPH_JClub. So I'm looking forward to another exciting webinar presentation and a thoughtful discussion. But just before we begin, a little bit of housekeeping. So as Danielle mentioned, all participants are muted, but we hope to engage you through different features. So the toolbar at the bottom of your screen has a few features. So if you have any general comments, please post them in the chat box and these will be visible to all participants. And we also encourage you to chat amongst yourselves both in the chat box and on Twitter. If you have any questions for the presenters, please post them in the Q&A box and these will be visible to all presenters and your questions will be answered in sequence. So this webinar is being recorded and the recording will be available to all our members and registered participants shortly following today's session. And slides and recordings will be available more broadly in the next 3 months. So before we begin, just a few poll questions for you guys. So where are you guys coming from today? So we have a lot of people from Ontario, which is to be expected with CPHA, but also some people from out east. And for today's session, what's your primary area or primary interest for today's paper's discussion? So very exciting for me. I love methods. So I hope that the audience is also feeling the same. So we're really exciting to have today's discussion. And our final question, where are you currently at in your studies or career path? So it looks like we have a great mix of PhD students at early career, so that should be really interesting. So I would like to take a moment to introduce today's speakers. So our presenter today is Andrew Basham. Andrew is a PhD candidate in the School of Population and Public Health at the University of British Columbia and is located at the British Columbia Centre for Disease Control. His research includes epidemiological research into the long-term health outcomes of tuberculosis survivors. And before starting his PhD, Andrew was a data analyst for the Manitoba Centre for Health Policy, where he linked and analyzed administrative data on a regular basis. Our author, Dr. Michelle Murti, is a public health physician at Public Health Ontario. Her work focuses on providing knowledge, tools, and support to understanding and controlling communicable diseases and improving emergency preparedness and response. She is passionate about serving the people of Ontario, helping them live healthier lives and reducing health inequities in the province. And our other author, Christina Renda, is an epidemiologist lead on the communicable diseases team at Public Health Ontario. And her work focuses on respiratory diseases, HIV and AIDS, as well as hepatitis B and C. And her primary interests are infectious disease epidemiology and public health surveillance and knowledge translation. So without further ado, I'll pass this over to Andrew so he can begin his presentation.
Okay, thanks very much, Monica. I'm going to share my screen now, so we'll start the presentation. Okay, so today I'm presenting altogether now, aggregating multiple records to develop a person-based data set to integrate and enhance infectious disease surveillance in Ontario, Canada. The authors are listed there. We have Christina Renda and Michelle Murti on the line. My name is Andrew Basham. I'm a PhD candidate at UBC. Now, before I begin, I'd like to acknowledge that I am on the traditional ancestral unceded territory of the Musqueam people. Okay, so Syndemics. It is a synergistic epidemic. It involves two or more diseases and or social conditions that interact to enhance one another. Usually at least one condition is an infectious disease. For our setting, the Health Protection and Promotion Act of Ontario, it signifies diseases of public health significance, i.e. infectious, requires notification of the Ministry of Health for those diseases, and this falls into registries. It authorizes contact tracing by public health officials. And one issue is that public health surveillance reports generally on diseases individually rather than collective or overlapping syndemic. The Integrated Public Health Information System, or IFIS, is a tool for surveillance and reporting by public health and is the data source used in this study. And if I get anything mixed up along the way, please feel free to correct me, Christina and Michelle. So the objectives of this study were to first create a client-based infectious disease surveillance data set, so a syndemic client registry essentially. And second was to conduct some frequency analyses of multiple infectious diseases occurring in individuals, focusing on those with common risk factors. So the intervention was a syndemic client registry. The study population included people with one or more records of any of the 8 diseases below between 2006 and 2018. And these are the conditions. They're all infectious diseases, as you can see. So to create the syndemic client registry, an algorithm was employed. And this is the flowchart. So they started with 1.1 million records between 1990 and 2018. An a priori algorithm removed about 1,600 people, and I'll explain that algorithm in the next slide. After that removal, there was 857,000 individual people or clients, with about 1.1 million records. Clients who had no disease record on or after January 1, 2006, so about 34% or 35% were removed. And the final syndemic client registry included 470,000 people, 470,673 people, which had 659,000 records. So the a priori algorithm I mentioned, the rationale for it was that acute hepatitis B, chronic HBV, and HCV and HIV, IFAS data entry guidelines allow only one record for each of these. For tuberculosis, genotyping was able to differentiate new versus ongoing TB when 2 or more diagnoses were present within 12 months of each other from 2007 onward. And for chlamydia, gonorrhea, infectious, syphilis, and iGAS, public health units are instructed to enter only new infections. And in this slide, I'll show how the final database was assembled. So a person level data set of people with 1 or more reportable diseases between 2006 to 2018 was the end goal for this. So the syndemic client registry, that was that 470,000 people I mentioned a couple slides ago. And so that's people with any record from 2006 to 2018. And then merged onto that would be the hepatitis and HIV data. And if multiple records existed, they included only the earliest record from each of these. Next, chlamydia, gonorrhea, and syphilis, all records were included based on that a priori algorithm explained a minute ago. And finally, for tuberculosis, they included all records diagnosed 2007 onwards, as they were able to differentiate new versus pre-existing. And before 2007, if 2 or more records included within 12 months, they only used the earliest record. For the second objective, to look at the frequency of multiple disease events, the authors quantified the total number of clients and disease records. They quantified the number of disease records per client. They analyzed the number of records per client by disease type, and they examined epidemiologically relevant combinations of HIV, AIDS, and TB, HCV, HIV, and iGAS, and gonorrhea, HIV, AIDS, and syphilis. So in terms of looking at the record counts in person, at the bottom, you'll see they had 659,000 disease records associated with clients. And there was 470,000 individuals. That's our syndemic client registry. And 23% of the people had 2 or more conditions, and the maximum was 50 conditions was noted for one person, I suppose. And that's that number is those 3 percentages grouped. And here, this group actually represented 45% of all disease records. So that would be a very important group to be looking into. So in terms of specific epidemiologically relevant combinations, TB HIV co-occurrence happened in 2.6% of people. That's people with TB who also had HIV/AIDS positive test. In the literature, in Alberta, 5 to 8% of TB patients were reported to have HIV/AIDS between 2003 and 2008. And in Montreal, 9.3% of TB patients had an HIV/AIDS diagnosis in 2004-2009. So was this an underestimation or a true difference? And the authors can explain about that a bit later, or at any point in time if they'd like.
Do you want me to address it just really briefly now, Andrew? Or
if you'd like. Yep.
Okay, great. So I think just one thing to keep in mind is for those 2 studies that you listed for Alberta and Montreal, just sort of lenses to keep in mind all the time are looking into potential testing differences. So for example, in the Alberta study, it looks like they have sort of a universal HIV testing program for TB clients, and that may not be the case in other jurisdictions, so like in Quebec or in Ontario. So that's sort of an important lens and may contribute to the increased percentage. And as well, it's really important to keep in mind denominators. So in the Montreal study, it looks like that 9.3% is TB cases where there was an HIV status reported, as opposed to for all TB cases. And we know that that differs a little bit. So just a couple of explanations. And I know from previous TB and HIV co-infection reports that have been done in Ontario, some years ago, we do get around the same percentage. So it's not to say that it's not an underestimation. We know that using things like IFIS and passive surveillance systems, there's always an aspect of underestimation due to the nature of how the data is getting in. Yeah, I think there's some other things to consider.
Just the one last one, just to say that Ontario, uniquely compared to other provinces, has a very high rate of anonymous HIV testing. And so many individuals who are are not recorded as being HIV cases within our IFIS system because they're done through anonymous testing. So we definitely do have an additional number of people who would have HIV that would not be captured in this process.
Okay, great. That's a very good explanation. And I also note that in BC here, we have a fairly similar TB HIV proportion. So that all adds up to me. Thank you. Okay, so and the next slide, this shows the proportion of people with HCV, HIV, and iGAS. As you can see, it's relatively small. The HCV is the largest group of disease records. And I'm not going to go through these in detail right now, but I'm just going to present them as they are. In gonorrhea, HIV, AIDS, and syphilis, we can see that gonorrhea is also the largest group, but there is a substantial overlap with syphilis and HIV/AIDS. So these do represent these circles, the areas where they overlap represents a potentially very important group of people to follow up with in a person-centered care manner. So as I was asked to do a critical appraisal, I will do a brief overview of the limitations. So some things that are listed by the authors is that there's the timing of infection or disease was not available to them or was not reported on in this paper. Age, sex, geography, or SCS were not available. And one thing I noted that contacts between clients was not considered. The data and algorithm are not validated. So when I say not validated, I don't mean wrong. I just mean that sensitivity, specificity, kappa, et cetera, and other agreement type statistics are not available. And there need to be some form of gold standard, for example, medical chart review to calculate. And there's somewhat unclear generalizability to other Canadian or international jurisdictions. However, this isn't inherently generalizable as a concept since most places do maintain disease registries and they are generally linkable. But in practice, it may not be feasible everywhere. However, that's to be seen. Some of the next steps the authors identified were examining the timing between infections, and they specifically mentioned HIV, AIDS, and TB. So one question that was in the paper I noticed was that, or implied question was that have screening initiatives changed timing or prevalence of overlap? And for syphilis or gonorrhea and other STBBIs, there may be some PEP and PrEP implications based on the timing of syphilis and then later perhaps an HIV positive test down the line. So some key variables they'd like to add are age, sex, location, risk factors such as drug use or housing. And they would like to set up a knowledge exchange framework where they would report to public health stakeholders, and analysis priority setting is also conducted with public health stakeholders for relevance. So some questions for the authors. I had 3 questions here. So and I have one other question after. So what specific applications do you envision for this surveillance system in terms of person-centered care?
So I can sort of speak a little bit to what we were hoping to do. So this was sort of a pilot project, sort of a feasibility study to see, could we take the data that was in IFIS, so our reportable disease database, and then could we report routinely and regularly on these multiple infections, because it's not something that we were set up to do in the first place. So I think one of the applications, one of the things that we're looking to accomplish out of this study and some further studies that we're looking to do is to make this part of our routine reporting, and so that we can get it out into the field, so that we can keep track of it, so we can have a baseline and then know, are we experiencing increases? So clients with multiple diseases, is that going up over time? Are the combinations changing? So I think that's a really interesting and sort of crucial part to the work we were trying to get done.
I can sort of add to that from like a pragmatic level. I mean, when I was at a Officer of Health in British Columbia, we would have different teams. So we had a TB team, we had an HIV team, we had a hepatitis team. And we also had sort of a gender outreach teams. So we had sometimes like 4 or 5 different public health unit teams who were reaching out to the same client. And so I think that was, potentially an inefficiency on our side, but also not a very client-centered approach to now have potentially 5 different public health nurses trying to all reach the same individual. So I think part of the goal of this project was to say, like how often does that happen? Is that a one-off? Is that something that's rare, or is that something that's actually more common? And can we actually try to tailor the way that we're doing public health interventions for these individuals that would be more client-centric and meeting people where they are?
Okay, thank you. Just going to reshare my screen. My questions seem to have disappeared. Hold on here. Okay, so another question was about what other databases would you like to see merge with the IFAS-based system? And I know you mentioned this Ontario Marginalization Index, and maybe you can talk a bit more about that.
Sure. Yeah, so in Ontario, we have the Ontario Marginalization Index, and we have actually done some preliminary work to try and merge that information. So it talks about, there's different indices. So neighborhood diversity, and I believe there's four indices that we would look at merging on with our client-centered database to get a sense of how the infectious disease data clients map with those. And I think another aspect that we talked about doing was including other diseases. So I know, Andrew, you mentioned the ones that were included in our pilot program, but something we talked about for going forward is including additional diseases. So some enterics, other diseases, since there are many in our IFAS database that might be relevant to Syndemics. I don't know if Michelle has anything else to add.
Yeah, I mean, I think just fundamentally like that, the syndemics we talked about is sort of sometimes like 2 diseases, so like HIV and TB, where like having both infections can cause a differential impact for that individual. But mostly the way people think about syndemics is often that intersection beyond just the disease state, but also the social determinants of health in their lives. So, what about their access to care? What about their access to testing? What about their material social deprivation and disease? So I think that's the element that we want to bring in. We were able to start first by what we have in terms of the surveillance data on infectious diseases as the basis for that. But the goal over time would be to try to layer in some of the more equity-based issues that are underlying why do people have multiple infectious diseases.
Yeah, that's very important. The biosocial context should not be forgotten in this. And the last question is, how might improved case histories, and I don't really know the context in Ontario of case history taking, but how might improved case histories like sociodemographic data be used to identify or characterize syndemics in Ontario?
So I think that's going to become more and more relevant as we incorporate additional variables that you alluded to. So things like risk factors, especially. I think if we can get really great data on those being entered into our IFAS system, that would help obviously give us more information about potential syndemics and, as Michelle mentioned, the sociodemographic factors that might affect them.
Okay, thanks very much. And one last question I had, which was sort of born out of my own interest, and contact tracing data is something that might help elucidate some key risk groups. The more contacts a person has, the more likely they are to have multiple conditions, so high-risk contacts. Finding people in multiple contact databases would indicate a need for person-centered public health action to address common risk factors or treat multiple conditions. Do you think there is any potential value in including contact tracing data in syndemic surveillance systems in order to improve person-centered follow-up for high-risk contacts? So people in contact with like 2 or more infectious diseases.
I think there's definitely value in including contact information. So in IFAS, contact data is entered. It's just not necessarily entered for all diseases or for all cases, especially because for certain diseases like STIs, we often don't have a lot of information in order to do case follow-up. But I do definitely think that there's value, and I think so. We're transitioning from IFAS to a new reportable disease database following COVID. So it's definitely something worth moving forward into our new system to perhaps enable better data collection on the contact aspect of it.
I would say I think that, to know the name of the individual contact is probably not helpful. Like the number of contacts people have, like so the way that public health would approach contact tracing is to say, specifically we need to call these contacts to tell them that they've been in contact and often to get tested and further follow up. But at an individual level, I'm not sure if that would help us really understand the epidemic. I think it's sort of being able to think about how would we aggregate what we know about contacts, or probably more like a settings-based approach might be more useful. So often we might, capture a risk factor like homeless or underhoused, but would it be more helpful to now actually capture the settings that that person may have frequented? So did they go to this specific shelter, or are they using these specific services? So that if you could now see an accumulation of cases who are reporting similar types of specific settings, that a public health unit could follow up and target more specifically, as opposed to at that individual, who did they actually expose person level?
Good. Thanks very much for that. And I believe that's so some of the final implications, just as some takeaways from this system, is that they've provided a platform for syndemic surveillance in Ontario, and this can give insights into disease patterns of public health importance. It does look to be generalizable to other jurisdictions. Most jurisdictions do have individual disease registries that are often linkable, theoretically at least. And this could facilitate patient-centered care across infectious diseases. By adding the timing and potentially contact tracing data could change some public health follow-up. So I think that's the end of my presentation. I'd like to thank everybody and the panelists especially for attending, and please feel free to reach out to me on email or Twitter at these locations. And these are questions from the Journal Club, but I'll leave that for Monica to adjudicate how we go forward. And I believe I should stop sharing my screen. Okay, there we go.
Thank you so much, Andrew, for a great presentation. So as we wait for some questions to come in from the audience, I'm going to just give us some methodology specific questions that I have. And I guess the first thing I'll do at the top too, because I know we have attendees that come from all over the place who might not have a background in health administrative databases. So I'll just start by saying, for those of you who might not know what an algorithm is, I guess the simplest way to kind of think about it is think of it as like a recipe. So there's a finite number of steps that you want to take in order to make, like, I guess it's lunchtime. So like if you're making a pizza, there's a finite number of steps you want to take in order to be able to make that pizza. So in this case, thinking about the steps that we're taking in order to kind of link our data sets or put our data sets together, or to drive a certain number of cases that we want to link together for this database. And so I'm curious to know from the authors, why is it particularly important that, why are algorithms particularly important for health surveillance work, research and work?
I think that's a really great question. I just wanted to clarify. So IFAS is a little bit different than other administrative databases. So it's a case reporting database. So this is positive cases that have come in through the laboratory systems or through other health professionals through to our local public health units. So they have a verified lab slip that says, Christina is positive for X disease, and then they go in and they enter it by hand into the database. So it's a little bit different than other administrative databases where you're using sort of other sources like billing codes or hospital admissions in that respect. So the algorithm that Andrew really nicely summarized for our paper was mostly for taking, so basically we took all of the IFAS cases that met our inclusion criteria, and it was just ensuring that the cases that we wanted to include in our final data set were left. So some of the things that Andrew mentioned were just sort of going through and making sure that, we are assuming the health units are entering based on our data entry guidance, and so removing perhaps where there are duplicates, those kinds of things. I hope that makes sense and answers your question a little bit.
Yes, no, perfect. And so just to kind of add on to there, so why do you think that this type of the use of this type of algorithm is important for your health surveillance work? I just wanted to clarify that. Sorry, did I?
Sorry, I'm just trying to understand. So creating Syndemic, like a client-centered database, or specifically our algorithm to include the cases into our registry?
So the client-centered database.
Oh, I see. Okay. So I think it's really important because we often see diseases very siloed and not as an individual. And we know that individuals are the ones that are experiencing these conditions. And so being able to look at a person and understand a bit more about what they're going, like the diseases that they have over the time period, I think it is a really an interesting and more sort of holistic way of looking at disease surveillance, in addition to just, the diseases on their own. I don't know, Michelle, if you have anything to add about that.
No, I think a good explanation. I think the algorithm part of it is kind of a necessary feature to get to that end state. I mean, obviously no data set is perfect, and there's always some things that we need to work out in terms of how the information is collected within the reportable disease database. So, that there's things like, number of STIs. Like, so sometimes people might get tested and then maybe they might get tested again 3 weeks later. And sometimes it can be hard to tell, like, was that still somebody who just didn't clear, and so was this, or does that actually represent a new infection afterwards? So I think some kind of decision making and algorithm is necessary to say, what are we going to count as a new case? Is that one that's new now positive 3 weeks later? Is that a true new infection case, or is that still just related to the first one they had 3 weeks ago? So that kind of decision making is important for building what you have, and then we'd have a reproducible data set.
So in the creation of this data set, I'm curious to know if you performed any sensitivity analyses to kind of decide on what your final definitions would be. So I know that Andrew mentioned through the presentation in the paper that if someone had multiple records, you went with the earliest case record that they had. So I'm curious to know throughout your analysis, if you kind of played with different opportunities to kind of have different iterations of those definitions of which one you should include, and what that looked like?
So I don't believe we did for the episode date 1. I am having a bit of trouble remembering. I think we did for some of the STI records specifically, but as Michelle mentioned, so some of the sort of algorithm is going on in the background with the health units based on the data entry guidance that we've already given them. So they are making that determination outside of what we can see, and then that's what is left in the database is based on their sort of data cleaning already. So we did not do any sort of specific or reported sensitivity analysis for this.
I had a related question, if I may. In the paper, you state that you analyzed the final data set to verify algorithm application and ensure fidelity between the original data extract and the final data set. Just wondering if you could mention which types of analyses were performed in that.
I think it was mostly just ensuring that our SAS coding was performing the way we expected. So we would take a record basically through the SAS code and, did it end up where we expected in the various buckets. So, if the record from the original raw data set had XYZ diseases, did it end up being counted in all of the places that we expected, or did it get removed with the a priori algorithm, depending on those different things? So I hope that answers the question.
Yeah, very well. And that kind of work is the nitty gritty, not so fun part of doing this stuff that is very tough. And I commend the authors for making that happen.
Thank you.
Those are a very large data set to manage too. So
yes,
just definitely challenges of managing that size of code.
Yes, it's impossible to do them individually, of course. So yeah. Okay.
I'm also curious to know, I guess, why you made the choice for this type of analysis. You say it was kind of preliminary to kind of to not look at sensitivity and specificity of your net data, your cases. Sorry, your cases selection.
So I think part of it is time and capacity. So this isn't a research project necessarily. So we're all sort of full-time public health employees and have other necessary work that needs to get done. But I also think, again, it's a little bit different than in other, using other data sets where you would need to validate that the case is truly a case. Like I think you would be basically performing a sensitivity analysis on IFAS as a whole, and that's extremely time consuming. Not that it's not a valid endeavor, but it just wasn't in scope for what we were looking at for this project.
Yeah, I mean, our goal is surveillance. So I think that having a reproducible data set that's going to provide consistent reporting over time is more important than, 100% accuracy. I mean, I think the thing is we have the surveillance is what the surveillance is. I mean, we don't really have another gold standard to compare it to because we are anticipating that these are reportable diseases. So anything that would have been reported to the health units should have been entered. So we don't really have another standard by which to say, did they receive something that we didn't get? That shouldn't really happen. So, what we have is what we have. And I think that the ability to really kind of assess what these numbers are over time in that consistent way is probably more important to say, as Christina mentioned, like, what are the trends? Is the number of cases with TB who also have HIV infected, is that changing over time? Or how do we understand what's happening is more important than making sure we had the exact number at a specific time.
And just to add a little bit to what Michelle was saying, we have done some analysis in the past where we look at, for example, are there lab results in the lab section of IFAS and for each case? So for example, do we have a hepatitis C case in our database, but no lab results attached? So that would sort of speak to your question about sensitivity, because I mean, we don't necessarily have that ability to verify on a lab requisition that we could see, oh, this person is positive for hepatitis C and therefore should be in the database. So a little bit of it is trusting that the health units are entering the data as per their sort of legislated required, like they're mandated to do this entry and using the provincial case definition. So a little bit is trusting that they're doing that accurately. But I think it is definitely interesting to think about sort of doing some sort of within IFAS checks to see, hey, you have this person as positive for this disease, but actually in the lab requisition that you've uploaded, it says that they're negative. So, does some sort of data cleaning. So in that respect, we do annual data cleanup activities for our surveillance database. So when we do notice things that are not in alignment, we do send tasks over to the health units to get them to clarify and clean that up. But that's more of a system-wide, IFAS-wide yearly endeavor and less specifically about this paper. I hope that answers your question.
It does. And I just asked because we haven't actually talked about this type of stuff before, because I think with our previous research journal club meetings, we kind of talk more, we speak more to people in academia and researchers as well. And so I think that this is a really excellent example of how, algorithms or this type of data can be used in a really practical way to kind of solve practical problem solve public health through something such as public health surveillance. So it's really interesting to kind of see, to hear your perspective on this. Sorry, I didn't mean to cut you off, Andrew.
No, not at all. I'd just like to mention that it's actually pretty common in Canada. Almost no province has validated these systems because, for the reasons the authors stated. I did participate in one project in Manitoba where we took the Manitoba TB registry and validated against existing administrative data. And we looked at everything like this. Was the age recorded, date of birth recorded correctly? Was the location of her hospitalization? So there's a lot of fields in there that can be validated. And what we did find in that was that almost most of these things were very high, like 95% sensitivity and specificity. Although we did identify a few deficiencies, and those are things that public health was going to follow up on. And specifically, one interesting one was linking the registry with First Nation status registry from federal government. That was one area where there was notable differences. And that's all I'll say.
So one additional question I had was, so I know you mentioned in your paper that there's that New York study that examines viral hepatitis, tuberculosis, sexually transmitted diseases, and HIV. surveillance data, and they use a deterministic matching approach to kind of link records across the database. And so one thing, and as we mentioned earlier, sometimes data analysis is kind of messy. And so for those who might not have previous experience with doing this type of analysis, can you talk a little bit about the difference between probabilistic matching and deterministic matching, and how, and then what influence that the choice to do which one would have on your results, intended results?
So just to say that we actually didn't need to use any of that because our diseases are already integrated. So unlike in other jurisdictions where they are housed in separate and non-linked data sets, IFAS is linked by unique client IDs. So we didn't have to do any probabilistic or deterministic linkages to come out with our data set. We linked on the client ID that was the same across all of the diseases that we included.
That's very helpful. And I'll just mention here quickly that for those who might be interested in differences between deterministic and problematic approaches, so if you're thinking about deterministic, you're looking for an exact match between two records, and this is usually occurs in cases when you have really strong, high quality data. And probabilistic matching, which uses a Cisco approach to kind of measure the probability that two records match each other. And so it gives you can set it up to have probability weights, and that helps match the scores based on people who are, and it determines whether people are a match, a non-match, or a possible match. And so a follow-up question to that. So given that, as you mentioned, there are many public health units that use this system to kind of enter the health surveillance system. Can you talk a little bit about how Public Health Ontario manages the data quality on your end? And it's not something we actually get to talk about here, because typically we are using additional data sets from ChiHi or other things. So I'm curious to know how you guys manage your data quality on your end.
So we have data entry guidance for all of the health units for all of the diseases that we included, or actually all the diseases that we have in IFAS. And so it gives really detailed instructions about how the data is to be entered into the system. So what fields are mandatory, technologically mandatory, which ones are required for our provincial reporting, and which ones can be used at the discretion of the health unit. They're really long documents, hundreds of pages long for each disease. There's also webinars, and we have sometimes weekly or bi-weekly meetings with health units to talk through data entry issues. So a lot of it is communicating with health units to make sure everybody's on the same page with how they're entering things. We are seeing that, so outside of this paper, but like with COVID information as well. So I think it's about making sure that everybody is approaching things in a similar way. And if they have questions, they email us. And in terms of annual data cleaning, like I mentioned earlier, we do have reports that we run on a provincial basis that look at data quality indicators. And then when we notice there are issues, we follow up with health units to ensure that they make the changes. But health units are also really, really, really good about doing their own data quality checks, either on a weekly or bi-weekly basis, however frequently they need to. So they really own that data and are responsible for keeping it high quality, and they do a really, really good job for the most part.
No, that's super helpful. Thank you. Oh, sorry, Andrew. I'm not sure if you were talking. I didn't mean to cut you off.
No, not at all. No, I was just, I had one question about the access to STI testing and locations. That was something that had come up earlier, and I was just curious if it's okay if I ask another question about that. So not knowing much about Ontario's context, I was wondering if you could fill in some of the blanks for me on that one.
Yeah, I mean, sort of mentioned before that, part of the goal of this is to also then look at like more of the broader societal factors about why some of these, clients with multiple infections are happening. And so I think, one of the ones we've seen an application of this actually came from LA, where they try to map syndemic-based diseases, so mainly STIs, hepatitis, and HIV, to locations where STI clinics were located in that region by county. And so that's kind of something we've been interested in. We haven't been able to kind of get to that stage of the analysis yet, but thinking about, are there actually, sometimes I think like different kinds of information, like, is somebody who has multiple episodes of an STI, that's obviously not good for that person, but could that actually also represent better access to testing in that region because the person's actually been able to go to either a GP, an STI clinic, which can be sort of a private clinic, or sometimes run by public health units. Sometimes STI testing is done through emergency room. So various settings where people could be accessing that STI testing. But certainly like that actually, you know, if you saw that pairing to say high rates, but actually was located in areas with good access, whereas you had low rates in areas with low access to testing, you know, those low rates may actually be artificially low and not necessarily a good indicator that these are people who are not likely to get it. There's just, it's an undercount of what might be happening because people have poor access to testing. So I think that's definitely an interest area for us, you know, how to now pair a deeper understanding about what we're seeing through that client-based approach to say, you know, what other factors are associated with these.
That's very interesting. Yeah, sort of like a camera dark zone. You don't see what's happening there. So I'm curious, would the data like that be in the Ontario Marginalization Index, or is there a clinic? I guess the location of the clinics is publicly available. So that's
yeah. I mean, we would have access to like GP locations, so we would know sort of all GP providers in the community who might be offering STI testing. We would have places like community health centers or public health unit-based STI clinics. So mainly like often through like laboratory-based systems to see, you know, who's ordering the test and looking at what kind of ordering providers might be available to see where people are getting that from, and being able to map that to the areas would be a next step, but not an easy undertaking. So we haven't gone there yet, but certainly of interest for us.
I was going to say that sounds very methodologically challenging, but extremely useful and interesting. So I'll be interested to see where that happens. All right.
I'm also curious to know, so I know that the Ontario Ministry of Health recently decided to stop using the IPIS data system. And so I'm curious to know like how that has kind of impacted your work and I guess how that has kind of impacted this type of work for health surveillance, and if it's, and especially when you're thinking about how that might have impacted the changes, or if that's something that may impact the changes we were seeing here today within your paper.
So I think, so for COVID data collection, they've moved to a new system called CCM, so case and contact management. And I think the idea is to move all of our reportable diseases over into that new system at some point. I don't know the timeline for that, but I believe it's basically going to be a very similar database to what IPIS had, and so should hopefully allow us to continue to do this type of syndemic work, just using a different sort of underlying technological system.
Mm-hmm. Do you think that there's opportunity to kind of incorporate some of the things, additional variables that you weren't able, that aren't currently in IPIS, such as like the age, gender, geographic relation? Is that an opportunity to maybe incorporate some of that within the cases when you're taking those?
So they're in IPIS, those variables you mentioned, they're in IPIS. They just, they weren't included in our analysis for a variety of reasons, including, you know, we would have needed extra privacy, approvals and ethics approvals to get some of those variables into our analysis. So definitely those things would be captured in whatever the new system CCM is for these diseases. All of that would be there. But I think sort of going back to Andrew's point about perhaps collecting more robust contact information and perhaps other variables that maybe we had difficulty getting high quality data in IPIS, it's an opportunity for sure to perhaps redesign or redefine how those variables are collected in CCM.
Yeah, I think, you know, some of the really, I think, promising things about the pandemic is, you know, COVID has really shined a light on some of the social inequities about infectious diseases. And there's been a push to now collect like things like race ethnicity data or income data associated with cases, which had not been, you know, with the exception of HIV and collection of race ethnicity data, is not a routine part of most infectious disease surveillance. And so, you know, it still isn't part of legislative mandate. So for most infectious diseases that are reportable in the province, collection of race ethnicity is not an included factor that health units are mandated to collect. But even just having the platform to be able to collect it, so even if they don't have to collect it, that they could collect it if they wanted to, they're kind of we're interested to try to gather that information is now, and having a more consistent way to collect that information is, I think, a really exciting new feature about where we're going with infectious disease reporting in the province. as well as nationally.
And a lot of the times, socioeconomic status data is limited to things like income quintiles or area level measures. Smoking is another thing that's notoriously absent from almost all administrative and surveillance systems. I know in BC, we have like less than 5% of people in the tuberculosis registry have a smoking data recorded, but we know that's very much linked to their long-term health outcomes. Anyways, just another example of that.
No, that's super great. And I'd also mentioned too, and just like thinking from a methodology perspective, I know that there's different ways to account for that with your analysis, Andrew, thinking about smoking, like not having those data assets, but it would be a great asset to have those within the actual cases as well. I'm just gonna see.
The chat has been,
sorry, I was just gonna say, to add to what you were saying, Monica, that in addition to having it available technologically, it's also something to think about ensuring we have enough capacity for the health units who are actually performing the data collection and data entry, because you know, even if we're physically able to get that information into our system, if health units are really busy with doing other aspects, you know, things like risk factors or like smoking, like Andrew suggested, is often what gets dropped from entry, right? So I think that's just sort of a lens to always keep in mind, that these are, you know, people that are collecting the data, and so trying to build up that capacity is also really crucial.
Yeah, you don't have too much. Oh, go on.
I was going to say that also seems, especially if you, I think this also speaks to the importance of having like not just collecting data just to collect data, because there are people on the other end who put that in, and so it's important to always think about, you know, what's the purpose for the reason for that behind that. What were you going to add?
When it comes to analysis, there are also some interesting methods involving imputation approaches. I've seen in BC here, I've seen people link the Canadian Community Health Survey. There's like a subset of it that's linkable. Link it to a group of people in an administrative database, predict the smoking variables in there with administrative data, impute it for everybody, and then delete the CCHS data. So you're basically creating a variable out of nothing based on a lot of fancy statistics, but it actually does perform reasonably well compared to what we might expect. So that's just a random thought there.
So I see that we're getting close to the end of the session. The hour always goes by very fast. So I just want to take some time to thank our presenters today. Thank you, Andrew, Michelle, and Christina, for this wonderful discussion. And I just wanted to let you guys know that our next final Journalist Club session of 2020-2021 will take place on April 28th. From 1 to 2 p.m., where we will discuss the paper Anemia, Iron Status, and Associated Protective Factors Among Children and Adolescents aged 3 to 19 years old from First Nations communities in Quebec, with the authors Ahmad Tahir and Dr. Melanie Lemire. And so CPHA members can register for free when logging to the CPHA members portal, and non-members should register from the webinar series webpage on CPHA's website. And if you really enjoyed today's session and are interested, a few other things that may be of interest are our COVID-19 and Public Health Forum, which will be held virtually from April 21st to 22nd. So the forum is a knowledgeable exchange event for public health and allied professionals, researchers, policymakers, academics, students, and trainees who are committed to sharing the research, best practices, and policies to prevent, reduce, and control the spread of COVID-19. And the virtual program will deliver a scientific program featuring plenary or abstracts and symposium sessions. On both of the days, and the program is now live and you can register today. We also have our CPHA annual conference, Public Health 2021, which we held using a virtual platform from October 6th to 8th. And so this is our national conference where attendees come together to kind of strengthen efforts to improve health and well-being, to share the latest research information, and to promote best practices and advocate for public health issues and policies and grounded research. And so registration will open on Thursday, April 8th. And if you're interested in sharing your research, the call for abstract submissions will close on Thursday, May 6th. And we're pleased to provide a discounted student registration rate. And if you aren't currently already, we encourage you to consider joining CPHA as a member. So membership is a great way to get to connect with Canadian public health professionals such as today. And there are many benefits to joining, such as other student opportunities. And you're eligible to participate in things like our mentorship program and other leadership roles. And so if you're interested in becoming a member and learning about current student early career activities, I'm more than happy to have a one-on-one conversation with you. So please feel free to reach out to me by email at students@cpha.ca. And on behalf of CPHA and the Canadian Journal of Public Health and the participants in today's webinar, I'd like to thank again Christina, Michelle, and Andrew for the presentations today. We hope this session was very insightful, and we look forward to hosting you next month. And if you have any additional questions, feel free to take us on Twitter at CJPHJ Club.
Thanks so much, Monica. It's a great experience.
Thank you so much, Andrew, Monica.
Bye, everyone.
Bye.
Thanks very much, everybody. Miigwech, thank you, merci. And we hope to see you at next month's webinar.